saying, thank you very much for this. I want to talk a little bit about the implications of the new strain of COVID for the homeless sector. Next slide, please. So I'm Andrew Hayward, otherwise known as the Scrooge or the Sage Scrooge. So this was really me highlighting some of the concerns that I had about people coming together for Christmas into sort of normal household circumstances where people are in close contact with each other for a long time. And of course, we also need to be concerned about how people without their own home are spending Christmas. And I'm so grateful for you all for coming together to think about how that's handled, but also more importantly, perhaps how we handle the next few months with this new strain of COVID transmitting. Next slide, please. So I won't spend long on this. I think you're all familiar with the three main ways in which COVID can transmit. Essentially, it's something that we breathe out, and we either breathe it out in large droplets, which will spread about up to 2 meters and can land directly on the person that you're close to, on their mucous membranes, etc., or be breathed in, or can drop to a surface and then be touched and rubbed into the eyes, etc. The other form of transmission, which I think has become more recognized throughout the pandemic, is the airborne transmission through aerosols, which are very, very small droplets that will float in the air and can potentially travel larger distances. And they're a particular problem if you're in rooms with lots of people in them. Oh, I seem to have lost the slide. Can you see the slides?
I'm seeing them in front of me. Delegates?
No, they've
James, I think you're sharing the wrong screen.
They were just seeing your screen, James, which has got Andrew on it.
Right. Okay. Let me.
We have got your screen.
Let me see what I can do about this. Okay, bear with me. Let's try that again. I'll go back to the previous slide for you, Andrew. Okay, no, we can see you. You seeing them now?
Yeah.
Yeah.
Okay, bear with me. I'll just get rid of some of those. Do that.
And again on slideshow if possible.
Yeah, just waiting for that to click through. Right, there we go.
Okay, and so I think the importance of the aerosol transmission is it's really about the number of people in a room and the level of ventilation in a room. So even if people are sitting 2.5 meters apart in a room for a long time that's poorly ventilated, that can lead to transmission. Next slide, please. So this new strain of COVID, I just wanted to explain what we know. It's very rapidly emerging issue that we've been discussing on nerve tags. So what we do know about it is that it's a strain that's got multiple mutations, and some of those mutations are in places that we might expect to change the level of infectivity, for example. We know that it probably emerged towards the end of September in the southeast of England, not sure exactly where. And we know that since then, it's gone on to become the dominant strain in some parts of the country, particularly in London, the southeast and the east of England. And that has essentially meant, particularly over the last month, there's been a very, very rapid increase in that particular strain type. And worryingly, this increase was starting to happen despite lockdown. So the measures that were sufficient to reduce COVID in most parts of the country were not sufficient to reduce this strain in the parts of the country that were affected. We know that this strain can affect all age groups, and it seems to have a similar age distribution, more or less, to the previous strains of COVID. We know that it can lead to hospitalizations and deaths in the same way as a normal strain of COVID can, but is still mainly mild disease. We know we've done some research recently looking at this in nursing homes, and we know that it's spread very effectively in nursing homes, both amongst residents and amongst staff. We know that although it's concentrated in the London and the southeast and east of England, it's present at some level in all parts of the country. And I think the most worrying aspect of this is that all of the data that we've been looking at suggests that the strain is perhaps around 50% more infectious than the previous strains. And backing that up, there's also some evidence that people with this virus, as opposed to other strains, have higher concentrations of virus when you do a swab, a diagnostic swab. And that's probably why they're more infectious. Next slide, please. There's a number of things we don't know, but I don't think we have any strong reason to think that these characteristics would differ from other strains of COVID. But we don't know for sure what the effect of the mutations are on severity. As I said before, we know that it will cause severe disease, but we've got no indication that it's more likely to. We don't know whether it changes duration of infectiousness or symptom profiles, or how fast it spreads between individuals. We don't know whether it's affecting making asymptomatic or pre-symptomatic people more infectious or not. And crucially, one of the things that we don't really know is whether or not the mutations would allow it to escape natural immunity. And we do have other information that suggests that natural immunity is actually about 95% effective over at least a few months, and vaccine-related immunity similarly, very high levels of protection over a few months. We don't have any particular reason to think that it would escape these forms of immunity, but until we've done the experiments over the next few weeks, we won't know for sure. Next slide, please. I just wanted to illustrate really the difference between an R of 1, which essentially means on average each person infects one other person, and this is, say, a notional hostel with an infected person on our left in the red on day 0. Next slide, please. And this is, say, 5 days later, so on average it takes about 5 days between cases. And so we can see this person's infected one other, but he's turned green because he's developing immunity himself. Next slide, please. And then it starts to spread on day 10. Next slide. And again on day 15. But then next slide, you may get to a situation where the next person doesn't transmit to anybody else. And so that little outbreak within a hostel essentially dies out naturally. Next slide, please. And again. So the main concern about this new strain is that even though you don't have increased levels of severity, if you've got increased levels of transmission, that can lead to very, very many more cases than you would expect, unless you tighten up control measures. Next slide, please. And so this next series of slides is really going to be illustrating what happens if you've got an R of 1.5, so a 50% increase on the previous slide. And we'll just, if you want to cycle through those slides for me, please. So we can see that as the epidemic goes on, it's much more likely to continue to spread and not die down, and that a high proportion of people could get infected in that way, with every person on average infecting, say, 1.5 others, is what an R of 1.5 means. Next slide, please. So what we did previously is we used some what's called mathematical modeling to model that sort of process across the entire homeless hostel and accommodation network in the country. And this slide's just illustrating how obviously we're sort of compartmentalized. Next slide, please. And what this model showed is actually we estimate that the interventions that you took and the whole sector took in terms of closing down the communal night shelters and the day centres, bringing in the Everybody In campaign, and perhaps actually most importantly, what was done across the sector in terms of the infection prevention and control measures that you were taking in hostels, as well as the reporting of cases and the rapid diagnosis and isolation of cases in COVID care, had a major impact on the number of cases and deaths that we would have otherwise expected in the first wave of the pandemic. And what this graph shows is a relatively small first wave. And if we continue these sorts of restrictions in the second wave, even if we have a sharp outbreak as we're seeing, if we have these control measures in place, we should be able to keep a lid on things. But next slide, please. This is sort of illustrating what happens if you lift those restrictions, what the model was showing. Next slide, please. And this is actually modelling that across 50 hostels, with the blue lines being each hostel and the number of cases in those hostels, and the red line being the overall number of cases across those hostels. And essentially what you can see in those situations is that if you've got good control, then the outbreaks will stay small and controllable, and with not too many people being affected in each hostel. But if one loosens them, what you can see is that some of the hostels can rapidly go to very high levels of infection, like we saw on those previous graphics. Next slide, please. This is a slide just to illustrate that point, if you like, of outbreaks in other parts of the world where I think the response in the homeless sector was less stringent than we had. In particular, I think a lot of these countries had communal shelters, and where that happened, we were reaching very high levels of infection. Next slide, please. And again, this is illustrating it from closer to home in the area around Paris. And the left-hand slide is showing that in those areas, up to about 50 or 60% of people in emergency homeless accommodation were becoming infected. And risk factors for that included sharing rooms, sharing bathrooms, and high crowding indices. By contrast, we've had a much, much lower proportion of homeless people in the UK become infected, and in fact not dissimilar to the proportion in the general population, around 6–7%. Next slide, please. This is really meant to illustrate that actually the many things that you can do to protect people, and I've drawn sort of multicolored lines, if you like, around people, showing if you like, a protective net of social distancing, hand washing, wearing masks, environmental cleaning, ventilation, etc. And then the dark lines around individuals. So we've got an isolated, infected individual on the left, and then isolating their contacts. Next slide, please. And we can see, okay, we've got a little bit of transmission, but next slide, please. But if you've got all of those measures in place, you can still contain an outbreak, even if you have an increased level of transmission or transmissibility. Next slide, please. So I quite like this Swiss cheese model, which is essentially sort of saying that, you know, when the times that you start to get really big problems in any system is when you've got all the holes in your defences lined up so that things can get through, and hence the Swiss cheese analogy. And I think that, you know, the most important line of defence that you've got is distancing. So keeping distance over 2 meters, and if people are in rooms for long periods, making sure they're ventilated. Wearing masks will stop or reduce quite a lot the extent to which people expel the virus when they breathe out. Obviously, environmental cleaning, hand washing, etc. But you need everything in place to make this difference. Next slide, please. And this is, I'm not going to go through this in detail because we don't have time, but I would encourage you to look at it in more detail. Now we'll take you through some of this. This is essentially the risk assessment type tool that we use in SAGE, which think about the things within the environment and human behavior that affect transmission, and what leads to low levels of transmission and what leads to high levels of transmission. I think all of these things you're doing already. I think my message is just keep on doing them, be extra alert. And that way I think we can get through this crisis and keep people protected until the vaccine comes along, which I expect there'll be some questions about, but maybe that might start in the new year. So I'll hand over to Al.
Thank you very much, Andrew. I'm going to do the blindingly obvious because if we do the blindingly obvious well, we'll get through this. We stand as an absolutely international exemplar, a model of success in terms of protecting the most vulnerable in our society, and the work that you've all done to mobilize, to work together, the partnership working to actually make this happen, to implement this plan, has been absolutely incredible in terms of the way it's reduced transmission. We've seen such enormous outbreaks with significant numbers of deaths amongst homeless people, particularly in the States and in some European countries. And as yet, we have not seen that here. But we're dealing now with a new scenario. We're dealing with a scenario where there's a mutation in this organism that increases its transmissibility. It's most likely a combination of two factors. It's binding better with the cells that it needs to replicate in, but perhaps most importantly, it's a much higher viral load in those people who are infectious. And so therefore, we're just going to have to up the ante in terms of what we do in terms of the basics. So I'm just going to talk you through, where our weak points are, in terms of where the virus is going to use as its line of attack. Rather scarily, we're currently dealing with 4 separate outbreaks among staff teams across London. And it would appear that when we try and untangle them with our colleagues in public health, it would appear that these are all attributable to people letting down their guard, which is an absolutely natural and human thing to do. But unfortunately, for the moment, it's not an option. These staff teams seem to have transmitted to one another in one of two ways. In the workplace, and invariably that was in workplace where masks weren't worn throughout. They were perhaps worn in some communal areas, and then people retreated to the safety of their office, and unfortunately they walked into a pea soup of this virus. And then secondly, and understandably again, when people try and let loose a little after work, and staff teams stick together, they support one another, and they do so in work and outside of work. We have stood down AMU, we have stood down multiple wards in a hospital because staff teams socialise outside of work and transmit. I don't want to be the Grinch, that's Andrew's job, but I just, as I just can't reiterate enough the importance of not letting down your guard. Don't come to work if you have symptoms. If you're even slightly unsure, you need to be tested before you return to work. We're in a very different place now, as Gemma said at the beginning. When we first rode into wave 1, we had no PPE, we had no tests, we were flying by the seat of our pants. We're in a much stronger place now to do this right and beat it. So the face, the space, the hands is leading by example. There's no name and shame here, but we go into every single hospital, every single emergency accommodation project that's been stood up across the capital, and every week we're coming into face-to-face contact with staff teams who aren't wearing masks, with a very poor example being set to residents of that accommodation. I'm not here to police you. I'm here to implore you to understand the science and do the right thing. Masks are a very important way to lead by example in terms of getting other residents to adopt face-to-face hands. And that's outside of work as well as inside of work. Next slide, please. The residents are, as we know, some of the more interesting people we could ever meet, and it's a joy to work with them. And some of them come with some interesting hobbies and some unique challenges, and that's where the expertise of you as a non-clinical frontline workforce just comes into its own. And again, back to the importance of that partnership between clinical teams and yourselves. This is what's made this work. This is why we have had success so far. But when people come into your facilities, you must be aware of how they've arrived, where they've come from. There are a number of checks in place to hopefully make sure that people who are symptomatic are not arriving at your facilities, and there should be a clear and documented process of what's gone on before they walk through the door. Hats off to the Chain crew. This is now very accessible to all of you through Chain. The risk assessment for symptoms and the risk assessment for clinical risk factors is built into the Chain database and accessible to us all online. It's very easy to check. As a frontline non-clinical workforce, I think you have been absolutely fantastic at extending your role, and wherever we go, we reinforce this message. Most places we don't need to because it's being done, but welfare checks should equal symptom checks, and this has to be done on a daily basis. We've got to be able to work with people in such a way as they feel safe to report symptoms. There's going to be no penalty, and again, we've got to be able to encourage people who have the genuine concerns in terms of coming forward. We've got to be able to allay those fears. So we've got to encourage residents to follow the same example that we set. We've got to encourage them to get tested. I'm going to go into a little bit more detail about that. Next slide, please. Symptoms. This is on the Chain database. This is not all the symptoms, but this is the most important four. And most people that we've tested, pretty much everyone we've tested who's positive has got one or more of these. Fever is a cyclical thing with this virus. So we will accept people who self-report the fact that they have had fever in the last 7 days. One thing quite unique about this virus is its ability to cause severe respiratory problems, and so people experience breathing difficulties. The cough, again, is complicated in our client group because there's a very high incidence of airways disease, and therefore don't think about the dry cough as being sort of unique. It can be a worsening of people's normal respiratory symptoms, particularly amongst people who smoked for many, many years or used crack and heroin, and a change in sense of smell or taste in the last 7 days. Any of these symptoms is sufficient to warrant a test. Hopefully you all know how to access a test. If you don't, call that number immediately and someone will answer it. Next slide, please. There are many symptoms. We've just looked at the most common ones. There's a couple of rule-ins. One in particular is shortness of breath. People who have COVID can deteriorate quite fast. That's why we are standing up COVID care again. That hopefully will be operational by the end of this week or early next. People who have underlying clinical risk factors are at greater risk of deteriorating, and they would need to be ideally supported through a period of isolation in COVID care. And again, we absolutely need you to encourage them to take up that offer. And just for your interest, sneezing is a good thing. It's very, very, very rare, almost unheard of in full-blown COVID. We've got circulating levels of influenza and common cold that are probably at an all-time low due to the amount of social distancing that's going on. So symptoms in terms of their predictive value are still very high for COVID. Next slide, please. This is probably the bigger challenge. We are a part of our community, and both our staff teams and our residents interact with their local community. Stay in is a very big ask. People will need support to stay in. We've put in place with colleagues from SLAM and with all of you some unprecedented work to get people access to scripts, some great work to enable people to manage their alcohol dependence, We are not setting up COVID Protect facilities or COVID care facilities as detoxes. We have to work with people where they're at. And again, hats off to you for leading by example in terms of creating an environment where people can come forward and have frank discussions with you about their needs and finding solutions that will enable them to, wherever possible, isolate. There's always going to be a need for interaction with the local community, whether it be just some fresh air and being able to look at the sky. But just to continuously reinforce those messages is all our jobs for now. Next slide, please. We are testing across London, have been testing since 1st of April. We first got access to kits. We've been outreaching the test for the simple reason that it was very quickly apparent that the national strategy of test and trace, where you have to register online, go through a number of hoops, etc., and then administer your own test at home, was not going to work for our clients. It certainly works for a few, but by and large, it's not the optimal solution. So we've been using an outreach testing model. It works in a couple of ways. I'm just going to talk you through the first and perhaps most important line of defense, which is rapidly testing people who are symptomatic and their close contacts. We cannot do this unless you notify us of people who have symptoms. When you tell us that someone's symptomatic, you can notify us through the email route or direct by phone. But when you notify us, that will initiate a triage where a nurse who's vastly experienced now at triaging people for the clinical presentation of this nasty disease will talk through with the client and with their key worker where possible and make a decision as to whether or not a test is needed. In many cases it is. We will outreach that test. We will come to you. Again, we need your support to make sure that the person's in, just the simple stuff. We will not only test the client, we will also test people who are a close contact of that client. I'm going to read this because it's important, but a close contact means having face-to-face contact with someone less than a metre away, even if a face covering or face mask is worn, or being within 2 metres of an infected person for 15 minutes or more. So it's not that difficult to be a close contact if we let our guard down. Next slide, please. Unfortunately, we've switched away from sort of sentinel testing, which is basically mass testing people to try and get a handle on whether or not there's a background prevalence of people who are positive and asymptomatic. And we're now full on outbreak management. Outbreak testing means everyone needs testing. If we don't get a high uptake when we're trying to close down outbreaks, it won't work. And we really need you to encourage people to get tested because everyone needs to be tested. The definition that we are currently using, as defined by colleagues in PHE, is if we get 2 or more test confirmed cases within 14 days. That would mean the entire facility would need to be screened. Next slide, please. I've coined the expression nose fatigue because it's, again, completely human nature. Having somebody who's dressed in PPE shove something into your nasopharynx is not a pleasant process. It's quick, but people who have been tested on multiple occasions can become reluctant to be retested. We need to be more imaginative and find ways to actually encourage people to overcome some of the barriers to testing. They are many. They include fear. They include fear that they may result in some sort of penalty. There's a lot of stigma associated with this disease, and obviously there's people who will refuse. We have protocols in place to manage people who will refuse, but if we're in an outbreak scenario and people refuse to be tested, as far as you're concerned, they are then considered COVID until proven otherwise, and they should be isolating for a period of at least 10 days with regular symptom checks. Next slide, please. We've made enormous progress in terms of being able to get the right tools in the right place. I don't think there's anything on this slide that any of you won't be familiar with. The top right picture is a skin sensing thermometer. It's good enough and it's safe to use. I hope you've all got one in the projects now, and most times when we actually ask people to take an objective measurement of temperature, they're able to do so. So please make sure you've got access to a skin sensing thermometer. A pulse oximeter is also very useful, particularly for older clients who may be experiencing shortness of breath. Really easy for the person to self-administer and do it themselves. If it's 92% or less, they may need help with oxygen. That's a 911. And then lastly, at the bottom, you can see this lateral flow test. There's been a lot of communication about these in the media recently. I'm not going to be offending anybody when I say that we have held the line and said that the sensitivity of this test is not sufficient to be a reliable indicator in people who do not have symptoms. It works very well and gives us a rapid result within 15 minutes that is reliable in people who've got symptoms, but amongst people who are asymptomatic, it is not a reliable test. We are advocating for PCR as the gold standard, and that's the test that's likely to detect the organism, even in people who've got low levels of virus. Next slide, please. I'm going to wrap it up now. This black line shows a pretty horrible journey, and we're all, at some point in time, we've probably been in very close proximity to this bug, and many of you will have already had it. As Andrew said, the problem now is that the R0 has changed, even when our normal control measures are in place, and even from the data that we've seen from London and the southeast recently, even when quite heavy levels of restriction are in place in terms of this virus was transmitting during a lockdown. The modelling, which is a red line at the end, shows a trajectory over the coming weeks and perhaps month or so, which is going to be extremely challenging to all of us. There is no easy solution to this. There is no easy way to put it, but there is a very clear evidence that if we do the basics right, and if we really ramp it up and don't let down our guard, and if we work with people where they're at and bring them with us, we can keep a lid on this until we can get sufficient numbers of people vaccinated to actually squash this bug. Next slide, please. My team are here for you, and you're here for us. This has been an incredible solidarity. We are at your disposal. If you need us, call us and we'll be there. Thank you very much.
Thank you, Al. I'm just going to try and attempt to come off, stop sharing my screen. So bear with me while I do that. And we've got some good questions that have come in as well. So, oh, no, it's asking me if I want to leave the meeting. I don't want to do that.
Okay, I've lost sound from James. I don't know if you have as well. Are you there, James? Okay, I think we've lost James. Can people hear me?
Yes.
Yeah.
Yes.
Shall we have a quick look in the chat box then and just see what came in terms of questions?
Thanks, Gemma, for holding the fort there. Did we get going with the questions? I managed to rejoin an old meeting.
Not yet, just having a look at them. They sort of started, so someone was really interested in whether we really know anything about new symptoms that we should be aware of. And is this variant mainly being spread by the age group of 11 to 18? So I guess there's a question there really about how much do we know about this virus when we're thinking about any new measures that we adopt. Are there going to be more cases in the homeless population? So I think that's probably a question for you, Andrew. Obviously a lot's not known, is it?
I'm afraid it's not really known. I mean, I think we know that there's plenty of cases with exactly the sorts of symptoms that you would expect. What we don't know is there's many with other sorts of symptoms. It's too early to say. In terms of the sort of 11 to 19, I think at a community level, 11 to 19-year-olds have been important because they're the ones who've been mixing a lot, particularly in schools and universities. How relevant that is, in this population, I don't know. But it, make no mistake, it transmits very well between all age groups.
Gemma, I can pick up a couple if you like. Question, first one out of the bag actually was from Chris Devaney, who's a research fellow from the Oak Foundation. Chris was mentioning, so organisations in their area, Sheffield, reported service users travelling around the UK more and staying with family and friends. Does it pose a significant risk? Well, I think that probably the answer is yes to that. And is there any feasible measures that can be taken to minimise risk? Is this something that is a practical kind of asking the right questions sort of answer to this, or?
Well, I mean, I think this movement around the country is obviously something that we're trying to discourage, especially from Tier 4 areas out. And some areas, for example, Manchester, are asking people to self-isolate for, I can't remember if they've said 10 or 14 days, if they are moving out of Tier 4 areas into their area, which they shouldn't be in the first place. So, yeah, I don't have much to add to that.
Okay. Okay, a question from Megan Preston at Glassdoor. How could rapid testing be used to make a difference to services right now? Should organisations be pushing for access to rapid testing? How can we access low-cost, reliable rapid tests?
That's a question I'll take. The evidence is quite clear now that there's a very, very high probability that we'll miss people who've got even a high viral load with these rapid tests if they're asymptomatic. And unfortunately, the dream of being able to sort of mass population test with lateral flow assays to create an environment where you could almost say to people that, you know, you've got a sort of passport to go, that is not the case. That is not true. Where these tests work well and where they were designed to work well is for people who have got quite a high chance of being positive, i.e. they've got plenty of virus in them. So identifying people on the street who are symptomatic, we have trained multiple street outreach teams to use these tests. They can safely use them outside. We're not asking specifically them to test the person. We're asking them to support the person to self-test. These tests are just like a pregnancy test. You are able to get a result just on a strip and read it off within sort of 15 to 20 minutes, usually up to half an hour. And they are very useful to inform next steps in terms of a clinical decision in multiple environments. We've trained people how to use them, non-clinical workers how to use them in several accommodation projects. The first pilot was in Anchor House. They have been amazing. Again, this really starts to shave off some time in terms of how rapidly we can think of next steps in terms of getting people into an environment where they can safely isolate. There's a good supply of these tests. There's thousands being provided to local authority colleagues. I know some of whom will be on the phone. And I'm sure that, and because we've already had good positive discussions, that there's a real willingness to sort of share this resource and work together to make sure we can get these test kits in the right hands, in the right place where they can make a difference.
Great, thanks, Al. Just mention in passing, question from Denise, who I think the answer you've covered this in the end of your presentation, Al, but mentions I've recently tested positive due to mass testing. I've displayed no symptoms. Are there plans to extend asymptomatic testing? And I think you've covered that for now, or did you want to pick up anything else?
Well, I mean, I can pick up on it a little bit. I mean, obviously, this is being used more widely as a strategy by the government. I think many public health people have concerns about it. I think this is, you know, what you have to expect is that a high proportion of the people who test negative will actually have COVID, and quite a high proportion of the people who test positive won't have COVID. You know, that said, it can still potentially pick up some people that you might not otherwise. But I think it's also, you know, the frequency with which you need to do it in order to make a difference is really very high. And I think you'd be better advised to be putting your efforts on the basics of infection control and finding people with symptoms and getting them tested than that. Obviously, you know, work with your local public health colleagues if they've got things that they want to do with you and think about that. But that's our view on it.
Great, thanks, Andrew. Question, I think, from Jesse Fejemison. I hope I've got that pronunciation right. At SIH, are there any new known symptoms we should be aware of? Is the variant mainly being spread by the 11 to 18-year-old age group? And are there any new measures we should adopt in infection control?
We've covered that one, James.
Covered that one, right?
Yep.
So this is me scrolling through my phone.
Good
So,
what we did.
okay. Sneezing being moved out, being ruled out as interesting, been noted in the chat.
Yeah, I think the thing, the thing about this disease is it ranges from anything from asymptomatic to pretty much any symptom, and so there's no absolutes in this, if you see what I mean. If you've got someone sneezing with no other symptoms, that you would want them to isolate. But at some points you need to make decisions about who you test. Which I think is probably what Al was referring to.
Okay. A financial question, Madeline. I don't think you covered this one off, Gemma. Does the lack of financial support for staff having to self-isolate, particularly those in probation periods on 0-hour contracts who are not entitled to sick pay, does it incentivize people going to work? I think what we're saying here is there a kind of a perverse incentive to go to work, even if you're unwell? I guess
there is that £500 payment that anybody on low wages is entitled to if they're asked to self-isolate through being a contact or indeed a case. And I'm not entirely sure of the details of how to claim that, but perhaps that's something we need to put up on the HLP website if it's not already there, point people in the right direction.
That's very good suggestion. We'll put all the links to kind of all the ways you can get additional benefits, but I would also say talk to your organisation, talk to the people that you're working for as well, and appeal to good common sense to support you at that time.
I think that's also relevant to the residents as well, because many of them are in the sort of thriving London low and no pay job sector, and they too are entirely on the breadline, and we should perhaps be a bit more imaginative in terms of how we can make information available to people that would be an option to them, and they wouldn't actually just fall through the poverty crack into destitution.
I can see there's a lot of people saying, will you share the slides? We're very happy to share the slides.
Absolutely.
James will probably circulate.
Yeah, we'll put the recording and the slides up by tomorrow. We'll send the link out to the page that will have both of those on it. Two questions here from, I think it's Kendall. Both involve lots of FFP questions around masks, so I'll read them both out. If the variant is 50% more contagious, should staff be wearing FFP3 masks instead of FFP? Is the first bit, and second bit, or wearing FFP3 mask instead of FFP2. Hoping that means more to you than it does to me.
Yeah, I mean, essentially this is the difference between, if you like, the sort of normal surgical type masks. So what they recommend in the NHS is these fluid resistant surgical masks for pretty much everything, apart from aerosol generating procedures. And aerosol generating procedures are things like people being intubated, so they're not really going to happen within a hostel setting. And so we're not changing the guidance on that within the NHS, and I don't think there's a need to here. Of course, those masks and FFP3 masks, neither of them are 100% effective, and still social distancing is really important, despite the use of masks. But Al, you've got lots of practical experience with this.
Sure, I'd say that a mask is part of the Swiss cheese. So Andrew's Swiss cheese slide was quite useful in terms of the fact that we need to it's multiple things that work together that protect us. But just to be sort of really practical about it, the other day I was in a project, again, no naming and shaming. It's not, we're in December, whilst it's not Arctic, it's not particularly pleasant outside. But the interior space in this project, which was going to be used by clients, so there was going to be a reasonable footfall through there. It was balmy. It was beautiful. Everybody was in t-shirts. People were very, very, very nice and toasty. And this sort of draws into quite sharp focus the need to think about our air. This is an airborne bug. If we've got a window, it needs to be open. Get your jumper on if you need it, get your coat on. If you're wandering around in a t-shirt at work, then there's something wrong. You need to improve the ventilation of your building. You need to have air changes. It takes a while for the virus to build up into a sufficient soup that's actually going to be a loading dose that's going to cause infection. And if you're in a balmy, humid environment wearing a t-shirt, you're in the wrong place.
And that, I mean, that ventilation can be done without making things freezing. So, you know, although it can be easy to forget, but even if you open the window, you know, 3 or 4 times an hour, that will make a dramatic difference. If you can leave them open all the time, that's great. But there should be no need to freeze either.
You just reminded me, Al, that kind of one of those challenges between putting forward good policy and advice and actually making change happen, and the behaviours that sit in between. And so I was just thinking about sort of the actions that people will need to take after this webinar. And perhaps everyone could just reflect for a minute before you rush on to the next thing in your busy lives, whether it's buying Brussels sprouts or whatever it is. If you could just reflect on how is your behaviour going to have to change? Really evaluate for yourself, like, how strongly do I think I'm sticking to stuff at the moment? What would I change? How could I make it absolute custom and practice? And also, what's the message I'm going to pass on to other colleagues? Now, so many people have made the call today, but there are probably people who haven't been able to make the call. So how am I going to be an advocate for this and make sure I'm carrying the message back to the places that I go? So those 2 things, because we often give good advice and information and it doesn't often translate into action. So if everyone could think about that at the end of this call, that would be fantastic. Thank you.
And I think, I mean, one particular thing to think about is meal times, I guess. I think we know that sitting across the table from somebody for over the course of a meal does carry a risk of transmission, substantial risk of transmission, actually. When you look at data from contact tracing and people who've been contacts of people within a restaurant, for example, then that's leading to about 8% chance of transmission, something like that. So it's, you know, that's quite substantial. So I think much as we want to socialize and sit around the table, particularly at Christmas, we really need to think about how you can, you know, for example, stagger meal times so there's, you know, people sitting further apart, and particularly vulnerable people, potentially supporting them to eat in their rooms, but whilst not leaving them too socially isolated. So I think those sorts of things are, you know, they're not pleasant, but I think they're things that we really need to think about more at this time with this new strain.
Thanks, Andrew. Thanks, speakers, all 3 of you, for holding on. We've gone over time. I'm going to start. I'll come to you for kind of closing remarks in a moment. Thank you, delegates, for so many questions, lots coming in. I think, Gemma, maybe we can, as a team, kind of take some of those away and see what we can respond to in terms of getting that with the link tomorrow, and so we can get back on those. Yes, thanks for joining us all, but I'll just go to the speakers for a kind of some final remarks before we start to wrap up. So, Al, you're always a good person to start with some final remarks. I never thought I'd hear you agreeing with Edwina Curry in terms of putting on a jumper, but
never knowingly agree with Edwina Curry. So I think, you know, I'm sorry if we've told a few of you how to suck eggs, and but that's a good thing, because we've got some really strong evidence that we can do the basics. We can continue to do the basics. This is not a completely different virus. This is broadly the same virus. It's just tweaked its spike so it can attach better to ACE receptor cells. It's also tweaked itself in a few other ways so it can replicate at a rate of knots that we've never seen before and cause a really high viral load in people. This is why it's more infectious. It doesn't mean that the main lines of defense that we have in place are not going to work. All it means is that we've got to be better at making sure that our defenses are up. It also means that, you know, we're almost time limited on this now. Again, you know, back to where we were in March, when, you know, everyone came in and you know, what a phenomenal effort that was. What a phenomenal challenge it's been. We've risen to it, and I don't think we've got that long to go. I don't want to sound too optimistic, but we don't have that long to go. There is light at the end of this tunnel. There's people in the hospital being vaccinated as we speak. Unfortunately, not me. I was going to change my name to Aardvark, but you know, I'm not sure how they're working it out. The reality is there's light at the end of the tunnel. We need to find a way of just keeping sane and waiting safely. There is light at the end of this tunnel. We do the basics right, and we will get there.
Thank you, Al. Andrew, any closing remarks? Then maybe we can finish. Gemma, I know you've got a few things you need to say.
I think similar. This isn't forever. This new strain is serious, but it's not. You know, it's not magic. It still respects distance. It respects ventilation. So if you've got a well ventilated space with people 2+ meters apart wearing masks, then the risks are still going to be relatively minimal. We got to, you know, it's going to be a tough January and into February, but as we move through that, increasing numbers of people will be vaccinated. As we move into spring, the virus naturally will start to die down because of the change in the climate as well. And so I think, you know, this time next year, I'm very much hopeful that you'll be able to have your Christmas parties without having to worry about this sort of rubbish.
Thanks, Andrew. And Gemma, I know that you wanted to just remind people about, or thank people, I suppose, for what's been an incredible and challenging year. You're on mute, which is the line of 2020, if ever there was one.
Yeah, I just want to say you're all amazing, absolutely fantastic, and I know you're hugely appreciated by the people that you're helping. So thank you, everybody. Somebody did ask about vaccination. I'm just going to mention very briefly that thanks to Susan, who's on the line, we've been assured that in London all frontline workers can get free flu vaccination. We're now trying to escalate up the kind of COVID vaccination list, the needs of these workers, but the flu vaccination is a good example of it's recognised that actually as frontline workers you're on that first line support for COVID, and therefore are quite a high risk group, so require that support. So thank you, everybody, and just want to say thank you and Merry Christmas, and I hope that we'll be able to come together again as a group under different times in the future, and to thank you again and celebrate all of what we've achieved through the course of this year. You should be extremely proud of yourselves. You've saved many, many lives. So thank you.
Thank you, Gemma. I'll call the meeting to a close on that perfect note. Thanks, everyone.